everyone, welcome to another episode of a StudyMRCPI YouTube series, which is AAA series. Of course, today I'll be talking about the most important topic, which is obstetric emergencies. Guys, this is Dr. Sowmya here. So I'm the COO and Co-Founder at StudyMedic. These obstetric emergencies, as we always say, you have to recognize, resuscitate, and move in the right decision. So today, the YouTube series is completely based on few emergencies and what difference you can make to treat as well as to answer questions in your exams. So to start with, remember to enjoy the journey. And of course, it's you who is going to perform well in the exam. Right now, start loving your journey and have fun. So automatically the journey becomes easier and you will definitely come out with flying colors. Let's kickstart. So to start with, approach to obstetric emergency patient. Obviously, we need to understand the physiological changes which will be there, the different targets, different hemodynamic changes which happens in the physiological adaptation in pregnancy. Let's remember the most important thing during resuscitation, you should always think of, especially once the mother is more than 24 weeks, you have to turn to left lateral to prevent supine hypotension syndrome. That's the reason you will always do an uterine displacement by giving cardiac wedge of 15 degrees. And you can do a fetal assessment during maternal resuscitation, but the most important thing is mother is the priority. And of course, if you are dealing with a maternal collapse, the most important thing is somebody should be recording the time. At the end of 4 minutes, you are going to do a perimartum cesarean section wherever the patient is, not shifting her to the OT. Probably if she's in labor room, A&E, you would immediately do perimartum cesarean section. This is done purely for effective maternal resuscitation and not for the baby's sake, so that the team can resuscitate the mother well. And of course, you have to be treating the mother first and prioritize maternal resuscitation first. So yes, the monitoring chart, IMEOS, this is something which you all need to be aware. Of course, they have given a trigger keys, and in the exams, you will be asked what happens if there is one yellow, two yellow, one pink, or more than two yellows or more than two pinks, what it means. Okay. Just to tell you the gist, respiratory rate is the earliest deterioration sign in pregnancy. Tachypnea, you should always think of sepsis until otherwise proven. And of course, any change in orientation or AVPU change which you cause alert, you should escalate. And of course, if you're suspecting sepsis, the first R is the gold. Okay, for sepsis, remember the first R is the golden R, because with every passing R, the mortality increases. If you are suspecting sepsis, within 1 hour antibiotics to be given. And remember the most important thing, IMEOS is not used during active labor. So because I was covering the resuscitation, this was important to touch upon this monitoring. Of course, this is the common questions which they ask, 2 yellow or 1 pink when you are going to review. Observation after 30 minutes, more than or equal to 2 yellow or more than or equal to 2 pinks. You have to immediate obstetric review, and again, either continuous or after 15 minutes based on the situation. Now coming to the maternal collapse, guys, very, very important thing, protocols which you need to be aware. So the first and foremost thing is you have to make sure that the environment is safe. And once, for example, you're walking in the hospital corridor, somebody collapses, then first and foremost, you have to simulate and assess response, whether she is alive or not. That's the first thing. You'll call out name, hi, hello, how are you? Or probably you will just call out the name with the hospital band, whatever. If they respond, then immediately you're going to do a uterine displacement. Probably there could be some giddiness or hypotension which would have happened. If that is not the case, you are not getting any visible response even on tapping on her and calling her name, then you have to immediately shout for help, call for help, and open the airway and quickly assess her breathing for 10 seconds. Okay. If there is no breathing, please start the CPR immediately. And remember, because it is pregnant, we are dealing with a pregnant woman, the maternal uterine displacement or the left lateral tilt is must before you go ahead. Not the complete left lateral position. Uterine displacement is the key here. Okay, and you would quickly start CPR. Remember, it is 30 chest compressions and 2 ventilations. So 30:2. Okay, and once your team has arrived, then you would be going ahead. Once you start the spontaneous breathing, you will be seeing the rhythm by attaching the defibrillator. Of course, if it is asystole or pulseless activity, this is extremely important. If the ECG is straight, asystole, pulseless activity, you continue to do the CPR. If there is anything like a ventricular fibrillation or ventricular tachycardia, that means electrical activity is regained, then you go ahead with the shock, either 200 joule biphasic or 360 joule monophasic. This is extremely important. And in all this time, you would have started recording the time. If once it crosses 4 minutes, you are going to do a perimartum cesarean section, taking out the baby and making sure that the resuscitation becomes effective. Okay. Of course, once if the woman recovers, then you have to debrief and documentation, incident reporting, all those things comes to the picture. So your exam point is what to do when. This is an extremely important SBAs which you would be getting, which I will be discussing in the coming slides. So let's look into the scenarios. A 28 weeks pregnant woman collapses, no pulse apneic. Okay, she is unresponsive, no breathing, no pulse, and she is more than 20 weeks. So what do? You have already checked her response. You have checked there is no breathing. So obviously you give a manual uterine displacement towards the left and start CPR. So the thing is, you have checked and there is no breathing, no pulse, you've called for help, and the next thing which you do is CPR. Okay, remember this is extremely important. Not breathing, CPR, more than 20 weeks, you are going to do a uterine displacement. Next, 34-week woman fainted, now breathing, pulse is present. Okay, collapse but breathing normally. So place her in a recovery position, again with the uterine displacement, and then because she is breathing normally, you have to look into the other causes, what it has happened. Cardiac arrest and there is ventricular fibrillation. For example, 32 weeks woman in arrest rhythm, what do you do next? Obviously, the next thing is you deliver the shock because there is electrical activity. There is asystole or PE rhythm for somebody who has collapsed. Continue the CPR because no amount of shock can get the electrical activity back. So continue the CPR. And no resuscitative efforts after 4 minutes, perimartum, and deliver the baby. During CPR, anytime, like any rhythm, there are a couple of things which you still keep doing simultaneously. One is you would have called for help, you would have done an uterine displacement. Along with that, you have to start having an IV access, oxygen, and probably adrenaline based on requirements. Okay, and of course, you have to be searching for the reasons of collapse, that 4Ts, foreheads, and eclampsia. So remember, these are extremely important. You have to resuscitate, you have to look for the cause, you have to monitor and continue to do the resuscitation. So basically, these are the next steps of action which you generally ask. They give a scenario where somebody is collapsed in the hospital floor. You are the first one who are seeing them. So open airway, check signs of life, then you call for help. The first step, when somebody collapses right in front of you, open airway and check signs of life. Okay, the next scenario, 32 weeks, collapsed, open airway, no signs of breathing. So you have just checked your open airway and calling for the help and also wedge tilt the patient. And you have called for help, no signs of breathing. Obviously, CPR, you would start off in the ratio of 30:2. 4 minutes over, perimartum CS. Rhythm ventricular fibrillation, shockable rhythm. Because this is shockable, you go ahead and give the biphasic or the monophasic one. Ongoing rhythms, asystole, please continue the CPR. Okay, so this is important. Before you call for help, confirm signs for life, open airway, and then call for help, and then no breathing, continue CPR, and more than 4 minutes, do the perimartum CS. And of course, if the rhythm shows ventricular fibrillation, go for the shock. If asystole, resume the CPR. Okay, these steps are important, guys, because each one can come as an SBA. Now let's see the question. what is the most appropriate immediate next step? A 33-year-old at 30 weeks suddenly collapses on antenatal ward. The emergency buzzer is pressed immediately. So help is called. You are the first doctor to arrive. She is unresponsive and not breathing normally. So called, it has been checked. No signs that she has collapsed, and you have been called for help. Third thing, no breathing. So obviously the next best thing, which comes to your mind would be start this CPR and manual uterine displacement. Okay, guys, hope this is easy and clear. Make sure to follow this protocol. Yes. Okay, I've already given the answer, but let's look at here. 36 to 37 weeks, emergency department with recurrent palpitation that have increased frequency over the past 2 days. Heart rate 220, blood pressure 120/80, no chest pain or syncope, saturation normal. ECG shows regular, narrow, complex tachycardia. So probably the most common is supraventricular tachycardia in pregnant women. So what is the most appropriate next step? Of course, massaging the vagal, see the vagal maneuver. Okay, so that could be the first line, but because the heart rate is 220, you go for medication, which could be IV adenosine. Okay, so that's the reason you have to be analyzing. Of course, they don't give the ECG. This is purely for your help. So IV adenosine could be given for supraventricular tachycardia. Rest of the things are like cardioversion is not required here because we are not dealing with ventricular fibrillation. IV amiodarone is not suitable for SVT. Magnesium sulfate, you don't think of it. CS is not for the maternal condition here. It is required. Okay, clear? Okay, next, one of the most important guideline obstetric emergency which we all come across is postpartum hemorrhage. It's a huge guideline. I have taken few things to explain. Of course, you have to know the ABCD approach, starting the IV cannulas, oxygen. Of course, you have to know atonic, traumatic, DIZ, what is the cause, and you need to know the uterotonic sequence, oxytocin, then comes ergometrin. If it is hypertensive, you avoid. You then move to carboplast. If it is asthmatic, avoid. Then comes your misoprostol. Tranexamic acid, you can give in the early phase and can repeat as well. Escalation threshold, once the estimated blood loss is more than a liter or 1000 ml, senior review plus blood test, more than 1500 ml, code red or MHP or massive hemorrhage protocol you would activate. Of course, this is extremely important to understand what is the transfusion targets. You need to make sure that hemoglobin is more than 7, platelets is more than 50, fibrinogen is more than 2. And of course, for the atonic PPH, after the medical management, the next thing would be balloon tamponade, then hemostatic sutures like B-Lynch, uterine artery ligation, hysterectomy, the earlier the better. Okay. So obviously you all know about the definition to everything. I have only covered the most important thing. So you need to know, like within 24 hours of birth, what you call, when it is called major, when it is called massive. So please go through the guideline very thoroughly. Now, this is like a staged approach for the prevention and the management of the PPH, which is given in your guideline. So this is what I was trying to tell. More than 1500 ml, you are supposed to be activating MOH or life-threatening obstetric hemorrhage protocols. However, all women antepartum or intrapartum, you are supposed to be checking their risk factors like previous history of PPH, APH, macrosomia, polyhydramnios, so on and so forth. So you need to be counseling, doing a blood grouping aristriping, making sure she is not Jehovah, and always active management of third stage of labor. Once the PPH starts, the first thing which you do is get help. And the investigations, continuous monitoring, IV access, bloods, what you need to be taking. And of course, you have to empty the bladder along with whatever you are trying to do. More than 1000 ml, if it continues, you have started one IV line, then it becomes second IV access, and you have to inform the labs, and probably you would start thinking of moving towards the theater because it's already crossed more than a liter. And of course, MOH, that's major obstetric hemorrhage protocol, or life-threatening hemorrhages, you need to be thinking of surgery, anesthesia, and the massive blood transfusions. And once she recovers, you have to remember clinical and clinical governance, that ongoing transfusion strategies, the target levels to be maintained, the blood target levels to be maintained, and then VD risk assessed to be assessed. And you can start with mechanical and then go for pharmacological. And of course, documentation, debriefing the patient with duty of candor, and incident reporting. And of course, planning for telling her what happens in her next pregnancy as well. So a bit about blood and blood products. Remember, packed red blood cells always increases oxygen carrying capacity, and this will be always a first line in major hemorrhage. If you don't have the specific blood group, quickly you can give ORH negative blood. It is emergency one, and you need not delay the transfusion if you don't have the blood. FFPs increases the clotting factors. It corrects the prolonged PT and APTT. So it corrects prolonged PT, APTT. In case if your lab report shows PT is prolonged, you're going to go for FFP. Platelet, of course, thrombocytopenias are again can continue the bleeding. So that's the reason I've given the target levels in the next one. Cryoprecipitate increase the fibrinogen, and you have to be maintaining that for clotting mechanism to work. Fibrinogen concentrate, if you have in severe PPH, it can cause hypofibrinogenemia. So this would be a specific replacement because cryo adds on to few clotting factors as well. And of course, cell salvage are the autologous red cells. It is useful in case of Jehovah's or in case of placenta accreta. Now, these are the targets which you need to be having. Fibrinogen more than or equal to 2 gram. Platelet should always be maintained more than 50. Coagulation profile like prothrombin and PT and APTT should be less than 1.5 times the normal. If it is prolonged, it becomes more than 1.5. Hemoglobin in active bleeding, you always aim at keeping more than 8. And of course, massive hemorrhage, you call more than 1500 ml. Okay, guys. So let's see one of the question for the blood product. Which of the following is the most important blood product to administer next? So a 34-year-old postpartum hemorrhage, blood loss is 1600 ml. So we are looking at massive PPH. And of course, HB is 8.3, platelet 78, PT is mildly prolonged, fibrinogen 1.5, and the bleeding continues. So what is the one thing which you want to give an appropriate blood? Because mostly hemoglobin is maintained more than 8, platelet is more than 50, fibrinogen is definitely less than 2. And they said PT is mildly prolonged. We don't know how much it is prolonged. So the most evident is fibrinogen here. So I give them the cryoprecipitate because hypofibrinogenemia can cause a lot of bleeding. So that's the reason I would always give cryo here first. Okay. Of course, FFP you would do if at all, if it is PT, APTT is prolonged more than 1.5 times. Okay. A few things about the drugs. I think we all are aware. Oxytocin is the first line. You can give 10 units IM as prophylaxis, 5 units low IV, 40 units in 500 ml infusion. You won't be giving in hypertension, pre-eclampsia, cardiac disease because, this is for ergometrin. So you would be avoiding rapid IV bolus because it can cause sudden hypotension. So rapid IV bolus of oxytocin you would want to avoid. And in cardiac disease, you give probably the minimal fluid, you give slow transfusions. Ergometrin, we know it is really good agent to prevent PPH, but at the same time, because of the spasm it causes, it is not indicated in hypertension, preeclampsia, and cardiac disease. Symptometrin, a combination of oxytocin and ergometrin, you can use as a prophylaxis in high-risk women. Of course, you have to be avoiding in all these contraindications. Next comes carboprost. Carboprost is once again a very good drug. It's a third line, 250 micrograms. You can repeat every 15 minutes, maximum 8 doses, avoid in asthma. And also caution in cardiac and hepatic. Misoprostol, it only can act as adjunct. It can cause side effects like fever and shivering. Tranexamic acid, of course, you can use in early use in PPH, 1 gram IV. And also you can repeat, but the problem is you won't be using in somebody who has got a history of VTE, because it should be used with caution in thromboembolic diseases and renal impairment. Fibrinogen or cryoprecipitate, you can monitor coagulation and give, because this will come under blood and blood products. Platelets less than 50, FFP you will give in terms of coagulopathy, which we discussed during the last slide. Okay, fantastic. So let's see few things on the drugs. 30-year-old man develops heavy vaginal bleeding 10 minutes after the vaginal delivery. Uterus is boggy, so we are dealing with atonic uterus. Blood pressure 150/100, severe preeclampsia. Oxytocin infusion has already been started. So obviously, the next best choice would be carboprost, because you cannot give ergometrin, and tranexamic acid at this point of time might not be the best uterotonic. If you want, you could give as an adjunctive, which could have given in a before. Okay. Next one, 29-year-old develops PPH following vaginal delivery. History of severe asthma. Obviously, then you are not going to give carboprost. Oxytocin as administered, bleeding continuous. Which heterotonic should be avoided? Again, here we are asking should be avoided. That's the reason carboprost, because PGF2 alpha causes bronchospasm. Okay, perfect. Okay, this is a bit about the traumatic PPH. What is the most appropriate management option for controlling intraoperative bleeding? Lara Evans, 32-year-old woman, experienced PPH following a cesarean section. During the procedure, she sustained a tear in her. So if this is the uterus, she has sustained a left uterine wall tear extending into the broad ligament. So I am looking into the broad ligament tear. Despite the uterus is well contracted and perineum intact, the bleeding keep on happening. Okay, you are considering the next best step in the management. Guys, there is very important thing, because there is always a confusion between uterine and internal iliac artery. Remember, if anywhere the broad ligament is included, okay, so broad ligament hematoma or broad ligament is torn, you should always go for internal iliac artery, because this is the only one which will help to reduce the venous plexus injuries to the broad ligament and to the pelvic structures. If it is left lateral wall of the uterus is injured, you can go for uterine artery. Stepwise will always be uterine artery, then internal iliac. But if you are going to ligate the uterine artery, this is not going to help you, because the tear has extended into the broad ligament and it is bleeding. If you have come across this real case scenario, you know that it starts bleeding from venous plexus and all and around the broad ligament, and hematoma happens very quickly. So you have to ligate the internal iliac artery. Hope this is clear. Whenever the broad ligament tear, broad ligament hematomas are involved, you should think of internal iliac artery. If not, you can think of uterine artery. So a bit about internal iliac artery. Indications will be, of course, if you have tried uterine artery ligation, then the next thing in PPH could be internal iliac artery. Midline uterine perforations, large broad ligament or lateral pelvic hematomas, multiple cervical tears, lower segment uterine bleeding. Those are the indications, and of course they are less effective in placenta accreta for obvious reasons and not useful for uterine lacerations. Okay, so that's what I said. If at all, if it's purely an uterine laceration, you would think of uterine artery. Once it is extended to the broad ligament, you go for internal iliac. Okay, I've already given you the answer, but let's see what is the question. 34-year-old, multiparous, develops massive PPH during CS, blood loss 1800, uterus atonic initially, but responds partially to uterotonics. There is ongoing deep pelvic bleeding with expanding broad ligament hematoma, uterine compression sutures have been attempted, but bleeding persists. So obviously, you go for internal iliac artery ligation for the obvious reasons, because there is a broad ligament hematoma. The next one, a 30-year-old woman develops severe PPH, 1200 ml, atonic, received oxytocin, ergometrin, tranexamic acid, bimanual compression, bleeding continues. Uterus is enlarged and atonic. There is no broad ligament hematoma. Hemodynamical is stable. Wishes to preserve fertility. So stepwise, you would go for uterine artery ligation. Okay. Hope this is clear. Here you have a broad ligament hematoma. Here you have an atonic PPH not controlled by oxytocins. Okay. Fine. This then let's move to the other most important obstetric emergency, which is a shoulder dystocia. Okay, so I've given you a few images. Just remember, shoulder dystocia can happen even in normal size babies, and when it happens, you see the turtle sign and you know you have to act quickly. Always remember, whenever you have been called for shoulder dystocia, see it is unilateral or bilateral. Now let's look into the maneuvers. So the first and the foremost, whenever it is shoulder dystocia, you see what has been tried and you examine to confirm it is not bilateral, then move quickly with the maneuvers. The first one which is shown is Mack-Roberts maneuver, where you are going to flex and abduct the woman's legs. Basically, both the midwives on either side, they flex and abduct at the same time. So there is a rotation of the maternal pelvis towards the head, which increases the anteroposterior diameter. All these maneuvers work by increasing the anteroposterior diameter. And here, along with that, they are also giving a suprapubic pressure. Basically, with suprapubic pressure, you are trying to convert anteroposterior diameter to, like, you are trying to push the shoulder from anteroposterior to oblique, so the stuck shoulder can get released. And if both of them fail, you can think of giving episiotomy, not routine. It is only to help the maneuvers. You can either go for internal rotation maneuvers if there is an expert for that, or you can remove the posterior arm. Basic purpose is to give the space. Either you actually, if anterior shoulders are stuck, you're going to go and remove the posterior shoulder. So other shoulder gets automatically released. And meanwhile, if you are alone and the woman is healthy and she's not on epidural and things so on, you can put her into all fours. So this is the protocol of shoulder dystocia. Obviously, if these line fails, then you can go for zavinally, cleidotomy, symphysiotomy, which are disruptive procedures. So basically, I'll come back to this. So call for help, that's the first step. Mack-Roberts thighs to abdomen. Along with Mack-Roberts, you can try suprapubic pressure. So this first line is done. Then comes your second line, where before you doing an internal maneuvers or the rotation, you have to check the space. So you have to think of giving episiotomy, and then either of them, whichever the operator is like experienced, they can either choose internal rotation or the delivery of the posterior arm. Then once that is done, whichever works, after that you have to make sure that the baby is seen by the pediatrician, your consultant is informed, debriefing, documentation, all that. And if that doesn't work, you can even try way early all fours position. And if that doesn't work, you can repeat all over again. And all these third line, cleidotomy, that is making an intentional fracture of the clavicle. Zavinally, putting the baby back and taking for cesarean, one of the very difficult one. Or you can recoup on the pubic symphysis, make the space and take it out. Of course, there will be a lot of issues like urinary incontinence, so on and so forth. So third lines are generally not recommended, and it should be done by a senior one. So as I mentioned, these are the different ones, but the most important thing is, once you are diagnosed, calling for help, discourage pushing and no fundal pressure. Mack-Roberts, suprapubic episiotomy you would do, delivering the arms you would do, then you will go for all fours you can do and you can repeat. Remember, no fundal pressure and no pushing. Okay, fine, fantastic. So, and of course, the success rate for Mack-Roberts is 90% and all fours they say 83%. Fine. So let's see one of the SPAs. What is the most appropriate next step? 31-year-old multiparous delivers the fetal head at term. Head retracts against the perineum. Gentle downward traction fails to deliver the shoulder. This is an axial traction which you give along the line of the spine. And shoulder dystocia is diagnosed. So help has been called and patient is positioned with her buttocks at the edge of the bed. Obviously, the next best step would be to performing Mack-Roberts maneuver. Hope this is clear, guys. And zavinally is the third line, routine episiotomy. First of all, there is no routine. Episiotomy is done for internal rotation. You would proceed directly to internal rotation. You won't do because you have to try the first line maneuvers. And fundal pressure should never be given. Okay, then quickly about umbilical cord prolapse. Remember, you can always remember the mnemonic card. Umbilical cord prolapse are more common in breech, common in preterm, common in even an unengaged head. It can happen antepartum, or probably once they go into the intrapartum, and of course PPROMs and extremes of viability, you should be careful. And variable decelerations, wherever you see, you should always think of the card. So first and foremost thing, whenever there is a lady in labor, ruptures membrane, and there is variable deceleration, you should think of the card all the time. So you have to be considering at every vaginal examination, abnormal fetal heart rate with spontaneous rupture of membranes, as I mentioned, or after membrane rupture with risk factors like polyhydramnios, or probably transverse lie, or probably the baby's head is higher, preterm, of course, and you have to call immediately for help. Obstetrician, midwives, anesthetists, and of course the neonatal team. What would you do if you see a card presentation or a card prolapse? Card prolapse, you have to prevent the vasospasm. So what you do is you can fill the bladder, so automatically umbilical cord which is prolapse gets elevated, or you can manually elevate the presenting part. Encourage the woman to lie down on the left lateral and or the knee chest position with the head down. You can consider tocolysis if you think it takes some time to deliver. Okay, and decision for birth. See, if at all, if she is about to deliver, that's a different story. There is a cord prolapse and in early labor, if the CTG is normal with cord prolapse, you take for category 2. But if CTG is abnormal with cord prolapse, then it would be category 1. Okay, so remember, abnormal CTGs with cord prolapse is category 1. Normal CTG with cord prolapse would be cat 2. Okay, let's see the next question. What is the immediate management? A 28-year-old woman at 40 weeks brought to the labor ward by ambulance. Her community midwife was performing a stretch and sweep at home when the membranes ruptured 30 minutes ago. Immediately after the rupture of the membranes, umbilical cord was palpated below the vertex. On arrival, vaginal examination confirms a cord prolapse, cervix is 2 centimeters dilated, intermittent auscultation, fetal heart sound is still good. What is the immediate management? Because they have confirmed already the fetal heart sound, you would be going ahead to elevate the presenting part manually and prepare for category 1. Or because if at all, if it was given retrogradely, fill the bladder and elevate and shift for category 1, that's fine. Because I can't see category 2 here. Basically 2 centimeters card presentation. They say heart rate is good. So that's the reason you have to take up for CS. If they had not given heart rate, then you have to confirm the fetal heart rate before proceeding. Okay. So confirm the fetal heart rate and then proceed. Fine. Perfect. Then comes again the very common one, eclampsia. So obviously you have to call for help. This is a maternal emergency. So you need your senior consultant, your anesthetist, your neonatologist as well, if at all, if you decide to go ahead for the delivery, and the midwife in charge, and you have to activate emergency protocol. And the first and foremost thing is, please protect her airway, left lateral position, clear the airway, because there is a lot of time which like tongue bites can happen and she can actually aspirate. So that's the reason. Prepare for intubation if it is really required. Okay, and remember, airway adjunct is very important post the eclampsia, because they would be very drowsy as well. And breathing should be taken care, high flow oxygen, and continuously kickstart monitoring the observations starting from SpO2 to pulse, blood pressure, everything. And you start off 2 large bore IV cannulas. Of course, if the bloods have taken, it all depends, but if it is a fresh one, you have to do FBC, urea electrolytes, LFTs, clotting, coagulation profile, group and save, RFTs, and very important, strict fluid balance, because it can cause pulmonary edema. Then you have to immediately control the seizures. So that's the reason you give magnesium sulfate, which is given 4 gram IV over 5 to 10 minutes. And you would be giving 1 gram per IV as a maintenance dose, as a continuous infusion. And if seizure recurs, again, even with infusion, you can give a bolus dose of 2 gram. Meanwhile, you have to be doing, this is important for your SBA. and monitor the magnesium toxicity. Whenever the respiratory rate is more than 12, urine output more than 25 ml per hour, and as well as the first sign which goes off is patellar reflexes being absent. Okay, so the most important thing is whenever there is this, you have to keep on maintaining. But if at all, if the respiratory rate falls less than 12, urine output is less than 25 ml, deep renal reflexes are absent, it indicates toxicity. In that case, you would be giving 10 ml of 10% calcium gluconate. And along with all this, magnesium sulfate works as tocolytic, and it helps to prevent the seizures, and you have to be treating the blood pressures as well. Of course, you can give labetalol IV, hydralazine. Oral nifedipine is not preferred right now. You have to do basically the IV once, and then once the target is done, then you can think of starting on the nifedipine. But nifedipine is never started if she's on magnesium sulfate. And of course, along with all of that, meanwhile, you have to check the baby, check for help, and see whether you can deliver her as quickly as possible, whether she has reached the viability, and so on and so forth. So the most important things, you need to know the drugs. You need to know that you cannot overload the IV fluids. It is 85 ml per hour. And of course, along with that, monitoring for the magnesium toxicity and thinking of delivery is the most important things in eclampsia. And magnesium sulfate, I've given few things. Early toxicity sign, as I mentioned, loss of patellar reflex. Then comes respiratory depression and cardiac arrest, which is in severe one. And this is the antidote which you would be giving. Okay, fine. And of course, you have to stabilize the mother before you think of the delivery. Okay, then an SBA based on that. What is the most appropriate next step in immediate management? Okay, so I've given a little bit of a scenario. So let's see how we are going to solve. A 28-year-old woman at 28 weeks gestation presents to maternity triage with sudden onset severe headache, blurred vision, and left-sided facial droop. If it is only headache and blurred vision, I would think of impending eclampsia. But there is also left-sided facial droop. She is alert, anxious, but her blood pressure is 178 by 105. So the blood pressure is higher. No history of epilepsy or the chronic hypertension. Neurological is stable, but has reduced power in her left arm. So we are looking into a neurological event here. No signs of fetal distress. Most appropriate next step. Begin magnesium sulfate for SHE's prevention. Might not be appropriate for here because I am unable to explain the left-sided facial droop as well as the reduced power in the left arm. IV labetalol for acute blood pressure control. It could be given. And remember, asthmatics, you don't give IV labetalol, but that is not mentioned here. Arrange transfer to neuro ICU. You would still be doing, but that is not the appropriate step as of now because I need to definitely treat her. Commence immediate steroids and plan for delivery. That is a secondary consideration. Oral nifedipine and observe blood pressure for 2 to 4 hours. Because the blood pressure is higher with the neurological deficit, obviously I'll go for IV labetalol. Guys, hope this is clear. So it is not that impending, like if they say blurring and headache of vision, obviously you will be thinking of impending eclampsia unless otherwise proved. But because she has got neurological symptoms here, you have signs here, you have to be careful of controlling the blood pressure. Magnesium sulfate won't work here. Okay. And I think the last topic is sepsis. So this is from the HSE guide website. So remember, up to 42 days, you will always be vigilant for these things. Patient looks sick. As I mentioned, IMEOS more than or equal to 2 or more than or 1 equal to pink. And you have like probably patient, family, or a carer consent. And you have got somebody who had been treated for sepsis. You will make sure that you will look into the sepsis. If it is sepsis 6, they say sepsis 6 plus 1 bundle. That is, you will take 3 and give 3. What are the 3 things you are taking? Blood cultures, blood lactate, and urine. What are the 3 things you are giving? Oxygen, IV fluids, and antimicrobials within 1 hour. Okay, so they also say antimicrobials within 3 hours if you are expecting SIRS. Okay, but remember, for your exams, for antimicrobials within 1 hour. That's antibiotics within 1 hour for sepsis. That is the sepsis 6. And you have to continue to assess the management, because pregnancy itself is an immunodeficient state which can affect the way the woman has been treated. Of course, a few triggers. Suspecting infection, always think of sepsis in pregnancy and immediate postpartum. Any red flag, she's in shock, lactate more than 2, systolic blood pressure is less than 90, respiratory more than 30, tachycardia, altered conscious, low urine, begin sepsis 6, antibiotics within 1 hour. Why within 1 hour is, the first 1 hour is called the golden hour, because with every passing hour, there is the mortality of the woman increases by 8%. That's the reason you say first hour is the golden hour. But you don't see any red flag, but there are more than 2 SIRs, like temperature is less than 36 or more than or equal to 38. There is tachycardia, there is tachypnea, abnormal white cell count. Then you still need to give antibiotics, but they say you can take a relaxed 3 hours. This is not sepsis, this is SIRS. And start sepsis 6, which you are already aware. If any red flag, you start sepsis 6. Take 3 and give 3. And monitor, of course, and know the source of the infection so that you can effectively manage. Of course, MDT is a must thing, including your microbiologist there. And these are the red flags which you need to be remembering. Urine less than 0.5 ml per kg per hour is concerning. Okay. And hypotension. Okay. In all these cases, you go ahead and give antibiotics with taking the cultures first. And recommended prophylactic, probably antibiotics as a part of the thing, because you would be asked many times what you would be giving. So cesarean section, obviously cefazolin 2 grams or cefuroxime 1.5 gram plus metronidazole 500 mg. If penicillin allergy, then you go for clindamycin, Clinda and Genta. Abdominal hysterectomies, IV cefazolin or cefuroxime, metronidazole. Allergy, you go for Clinda and Genta. Vaginal hysterectomies, cefazolin and metronidazole. If penicillin allergic, again Clinda and Genta. Perineal procedures, you always think of giving IV cefuroxime, metronidazole 500 milligram, or you can give co-amoxiclav also. Penicillin allergy, you go for gentamicin, and metronidazole are followed by clindamycin. MRSA positive, IV teicoplanin and gentamicin is preferred. Some of the antibiotic doses which you need to be aware for your exams. Okay, let's see one of the SPAs. 29-year-old woman, 2 days postpartum, presents with fever, abdominal pain, temperature 38.4, tachycardia, hypotension, tachypnea, lactate more than 2, urine output is less. Of course, I'm suspecting sepsis. Most appropriate immediate action would be, I would want to start IV antibiotics within 1 hour and initiate sepsis 6. Repeat observation, I don't want to do, I want to do continuous. Oral antibiotics won't help. RNCT I can still do, but first I want to treat. Wait for blood culture, which you won't do. Okay, hope that is clear and straightforward. So guys, I have covered the most important ones. There are still others, like probably rupture ectopic and antibiotic hemorrhage coming with the bleeding. So I have touched upon the most important obstetric emergencies. Hope this was useful. Remember, yesterday is history, tomorrow is a mystery, but today is a gift. So that's why it is called present. So make use of your present well. I know your exams are fast approaching. Make the best use of the time and you'll all be coming out with the flying colors. Don't forget to subscribe the YouTube series to watch such concept-based videos which will help in your preparation. Thank you so much, guys, and may success be yours. Thank you.